every 15 minutes or so was standard when I was an RN for an hour while they're getting it, and an hour afterwards. All right, so the next concept we're going to look at is how to stop region of the body from bleeding. But let's look at a little summary here. So based on what we've done so far, an individual demonstrates antibody A and B. So this is what they have in their blood already. We're not adding it looking for antigens, okay? This is what they have in their blood that they made themselves with their own lymphocytes. So they have antibodies A and antibodies B. So against the A antigen and against the B antigen. What would their blood type be? So I forgot to put this back up last night after I raised it to have room for my kids. So you guys know there's no overlap tomorrow. Jeff is in the East Coast, so that won't be counted against your total. Okay. All right, any ideas here? So for the letters, A, B, or O, what's the blood type? O. Positive or negative, or you can't tell?
You can't tell.
You can't tell.
So if you want us to select all that option, all that could be just.
That's how I would have it on the multiple choice
Okay.
question. All right, and we never have BB. So as we move in, this is kind of a think about it before we talk about it question, and we can come back to it after you've gotten some information under your belt. So which of the following is also known as clotting? Okay. So I don't have agglutination up there, but that would not be a correct answer, because agglutination is the sticking together of the red blood cells, and that's not a clot. Okay. So these are the 3 steps of hemostasis. We'll look at each of them. Good more time with coagulation, but look at each of them for a period of time. Okay. So they would, all 3 of them would be hemostasis. Which of them qualify as clotting? And as I said, we can come back to this when you feel you have more information, rather than, you may already know the answer, but if you don't, we can come back to this. Okay? All right, so the 3 steps that I indicated earlier in hemostasis, if the blood vessel is cut, will include a vascular spasm. Okay? Sometimes people develop clots without damage to the blood vessel. So deep vein thrombosis, DVTs. You don't have to have damage to the tissue. It can be the pooling of the blood, so a long airplane ride. Deep vein means that usually we have venous tone, so we have some slight contraction of the muscles of deep veins. And when we walk, we said that your skeletal muscle contracts and shortens and massages those deep veins and helps to propel the blood back to the heart. So if you're sitting in a plane for 5 or 14 hours and you're not doing that, not only is the blood pooling like it would be if you were standing, but you're not walking around moving the blood up past the valve. And so as they pull, they start to settle on each other, and the platelets can start to stick, and that can trigger a clot without a cutting of a vessel. But if the vessel is cut, you cut your finger or step on something that cuts your foot, that's going to be the first reflexive response. So it's the actual cutting of the muscle cells that reflexively causes the sympathetic nervous system, because that's what causes both vessel constriction and vessel dilation. All right? And then steps 2 and 3 can occur without the cutting. All right? So all it takes for steps 2 and 3 is an injury to a blood vessel lining. That doesn't mean it could be inflammation, phlebitis. All right? Where the surface becomes rough, the simple squamous epithelium is uneven, and collagen fibers from below the epithelium are exposed. We talked about atrial fibrillation, leading to high risk of blood clots. And that's because there's an uneven movement of blood through the heart, and the cells can settle down into those trabecular carni and a clot formation. So that's occurring without a cut as well. So, as we'll see in that second step, we'll kind of go through these here. So, the reflex response from the cutting or the release of chemicals from the platelets now exposed to the collagen from the cutting can cause further vasoconstriction. All right? So vasoconstriction can be caused by either direct cut or by the chemicals released from the platelets as they are exposed now to the collagen fibers in the connective tissue after the cut. So a platelet plug, then some of you may have seen platelets, noticed them and not know what they were in your blood cells. So those are the tiny, small little purple dots, which, if you recall, are developed from the megakaryocytes. So these are large cells that are too large to leave the bone marrow, and instead the platelets are pinched off as plasma membrane sacs that contain primarily 3 chemicals. And those 3 chemicals, there's only two there. So those 3 chemicals are serotonin, which we know as a neurotransmitter in the brain that makes you feel good, but it's also produced by the megakaryocytes, all right? And it can cause further constriction of the blood vessels. ADP, we usually don't think of this as a signaler. It's the low energy form of ATP. It's found in platelets, and it causes, once the platelets start to stick, they're released and they increase platelet stickiness. So we actually get a plug that might block a torn opening in the vessel. And then thromboxane does both. So it also increases platelet stickiness and it causes vasoconstriction. So that's why serotonin and thromboxane were listed up here. Because after release by platelets, both of them can maintain or further increase the vasoconstriction. Now that's going to slow down blood loss from a cut vessel, okay? But neither of those are clots. So the vessel constriction is not a clot. And if the platelets start to get sticky, these are the platelets here. So they're interacting with some platelet clotting factors, not platelet, but clotting factors, and they're associated with collagen fibers. There's another clotting factor called von Willebrand that will bind to collagen. So here's our blood vessel, here's the damaged lining, exposing collagen, all right? And this von Willebrand factor will attach to the collagen, which further attracts platelets, and then you get the platelets becoming sticky. And those might even actually close off this opening and limit blood loss. But a platelet plug, in reference to the last slide that we had, is not a clot, all right? Clot requires polymerization of fibers. Clots require the polymerization of fibers so that we have dissolved in the blood. It was one of the proteins we talked about in plasma, but absent from serum. Remember that definition? First day of lecture on the blood. Plasma was all the fluid and the dissolved proteins. Serum was the same thing once the clotting proteins were been removed. All right? So any of the clotting factors are fibrin. So fibrin is a protein that in its soluble form is indistinguishable in the fluid. All right? It's like Jell-O, my favorite biological material. It's just a powder, even if you take out all the sugar. So unflavored Knox gelatin, the same thing. You add hot water to it and it still is liquid, it still pours. Water molecules are free to move. But as it cools, the gelatin proteins and our fibrins polymerize. And they make strands of fibrin. So these proteins that are fibrinogen, and these are threads, are fibrin. Okay? The closer the weave, when we talked about this in 4:30 in my class, talking about how size matters in a diffusion, rate of diffusion. So water is going to get trapped in these spaces between the threads. The smaller the spaces or the more threads they are, the less movable the water molecules become. So if this is Jell-O, the Jell-O firms up. All right, and it may be squiggly, jiggly, but it's not going to flow. And so that's what fibrin threads do. It traps the water molecules, and that is a clot, okay? So the process of coagulation is a process by which we activate these fibrinogen to polymerize and form a clot. We do not need red blood cells to form a clot. We do not need platelets to form a clot. If a clot is formed in a blood vessel, yes, those cell formed elements will be trapped within the fibers, but they don't need to be there. If we take blood and spin it down and remove the cells and have only plasma, it will clot. Okay, it'll become this straw-colored jello. That's why the clotting factors and proteins have to be removed to keep it from clotting, or else take out the calcium is another way of doing it. So a clot does not need any cells. All we need is water and our clotting factors and clotting proteins. Okay? So the rough surfaces of the cut vessels and sticky platelets can trigger the activity of a clot, the cascade of clot activation. That's a positive feedback activity. A clot formation is an example of positive feedback. So in this small diagram, it's showing the response to a platelet plug, although again, that's not required. You can take blood from a blood sample and put it in a glass tube and it will clot in that glass tube without a platelet plug, okay? But we have what's called the extrinsic factor and the extrinsic pathway and the intrinsic pathway. Extrinsic is shown here on the left, intrinsic is shown on the right, and no, you don't need to know all of those different numbers, okay? We're going to start with this factor X right here. As we'll see with complement activation, in many biochemical activities, the molecules involved are given numbers in the order in which they were identified. And they never go back and change it to the order in which they act. So it's totally confusing because the numbers are completely out of sequence many other times. And that is the reason why I don't have you learn the different factors, because it's not going to do us any good, and I forget it from year to year, so there's no point. If I can't remember it, I don't ask you guys to remember something. I don't remember from semester to semester if I don't think it's important. What I do want you to know is the reason why we call it extrinsic, okay? Extrinsic means outside of it. So in our tongue, we have intrinsic and extrinsic muscles. I have no control over my intrinsic. This means I say whatever comes out of my mouth. Intrinsic muscles are the ones about a quarter a centimeter deep on the surface of your tongue, and that's what allows you to taco roll your tongue or cloverleaf your tongue, and I can't do any of that. Okay? It's still skeletal muscle. Extrinsic are the ones that, like the genioglossus, that allow you to stick your tongue out, or the styloglossus that comes from the temporal bone and allows you to pull your tongue out. Those are coming from outside the tongue. Okay? So if the cause for coagulation comes from outside the blood, or the blood vessel wall, it's an extrinsic clotting factor. And the key is it involves this chemical, thromboplastin. Okay? That is produced by cells in the connective tissue around the blood vessels, and it requires that they be crushed or damaged. Sliding a needle into your vein is not going to cause the cells to produce thromboplastin. All right? So let's say you were in a motorcycle accident. The 21-year-old across the street just came home from the hospital Sunday night. He had been thrown or hit by when he was on his motorcycle, and both bones and his ankle are broken. So he has a lot of tissue thromboplastin release because the tissue around a comminuted, do you remember what a comminuted fracture was, a crushing fracture? That's going to crush the surrounding tissue, and they're going to release thromboplastin. The blood vessels are torn. So thromboplastin is going to come into the blood, trigger another couple of clotting factors, and trigger factor X. We'll come back to that. Intrinsic pathway. No additional chemical comes into the blood, all right? Instead, exposure to platelets, exposure to the collagen, the irregular surface, the settled platelets that we talked about in atrial fib a few minutes ago, an inflamed blood vessel, phlebitis, all right, any of those without external thromboplastin coming in. So a damaged cell wall without the thromboplastin will still trigger all of these factors, including the need for calcium, all right, to finally activate factor X. So anything that changes the fluid, the contact that these original factors up here, they're already in the blood, and most of them are produced by the liver, by the way. The liver is an essential organ for many things, but also for clotting. It makes it really difficult for someone who needs a liver transplant, because if they have liver cirrhosis or liver cancer or hepatitis, in which liver cells have been destroyed and replaced by scar tissue, they're not going to have clotting factors, or as many as they need. And obviously surgery is going to result in cutting and bleeding, and so they need to have an external source for those, and it makes it a little tricky to schedule surgery. So, no external source to trigger the cascade, the positive feedback cascade, if it's an intrinsic factor. It's a damaged surface, okay? Or an unusual surface. So, now we're going to start with the common pathway, okay? Before we get to that, I want to mention calcium again. One of the ways in which to keep blood from clotting that's been taken out of someone's veins for blood testing, they often will coat the blood vessel, the glass tube with heparin. And we'll see that heparin is an anticoagulant. But another thing is to add a chemical to the blood that binds calcium, takes calcium out of solution. And that's called chelating, to remove it from solution. So it's bound to this other molecule. In other words, troponin would be a calcium chelator. It takes calcium from being a free calcium ion, all right? So a calcium chelator is any molecule that binds to the calcium in the blood and keeps it from binding to our factors and activating them. So that's one way of keeping blood from clotting, okay? It removes calcium. So let's say that we have free calcium. Calcium ions have two positive charges. And so this could bind to a clotting factor and activate it, all right? Causing it to change its shape and be able to interact with other molecules. But if it binds to a calcium chelator, it's not available to bind to that. Bind to the clotting factor. So it removes it from interacting with the clotting factor. It doesn't completely take it out of the blood, it just keeps it from binding to the clotting factor. So this is a calcium chelator. Okay. So whether or not we've added thromboplastin, or we have a abnormal surface, with calcium, we're going to activate factor 10, which is going to activate an enzyme called prothrombinase. And factor 10 is going to take prothrombinase, cleave off some amino acids, and convert it to a molecule called prothrombin. Prothrombin acts as an enzyme activator and takes fibrinogen. That was our little soluble protein, and causes it to polymerize. So it's going to take our soluble fibrinogen and cause it to polymerize into fibrin threads. And those trap the water molecules. So back in the time when I would run labs that students could lance their own fingers and draw blood in a capillary, we talked about clotting time. Sometimes it's called PT, PTT, prothrombin time. And normal clotting time is around 2.5 minutes. Okay? So we draw up blood in a glass capillary tube. and not to do hematocrit, and wait a minute to a minute and a half, and then break it, okay? Just snap it, and if it's less than the 2.5 to 3 minutes, those two edges come out clean because there are no fibrin threads have been formed, okay? If, however, coagulation has started, then when you break the capillary tubes, they will be connected by thin strands of clotted blood. Okay, it's just a real quick way of has coagulation started yet? All right. You have to be careful not to start too early because then you're left with tiny little pieces of glass tubing that you're only half an inch, and that's hard to break when it's really tiny, unless you just make up multiple tubes and break one in a minute and a half and break another one at 2 minutes and another one at 2 minutes and 30 seconds or something. Okay. Higher viscosity would definitely have a higher sedimentation rate, but it doesn't necessarily mean that generally more proteins lead to higher viscosity. If those proteins are more fibrinogen, that's not going to really cause a faster clotting time unless it triggers. Remember, the fibrinogen by itself isn't going to clot. It requires the activation from all those steps. So unless the viscosity, and that in and of itself doesn't typically do that. It may trigger, if you're seated for a long time, it may trigger settling faster, but in and of itself isn't going to affect that. It would have to contribute to some other factors downstream. Okay? Now we don't want blood to we want it to clot, right? Otherwise we would all have some form of blood bleeding disorders, and we'd have to be very careful getting out of bed and shaving and cutting our fingernails and everything else, because if we started bleeding, it would never stop. So we don't want it to just clot, because then we would have all the time, because then we would have clots going to our lungs and our brains, and we'd never know when we were going to keel over with a stroke. So we do want clotting to occur when hemostasis needs to be regulated, but we don't want it to occur all the time, and we don't want that clot that once it's formed to trigger additional clotting or to never break down. All right, so we have both clotting factors and we have anti-clotting factors. So here's what some of the clotting factors are called. All right, even calcium ion is called a clotting factor. Many of them are made by the liver, but I wanted to recognize vitamin K. Vitamin K increases or decreases coagulation?
Increases.
Increases. All right, so anybody know where we get our vitamin K?
Free leafy vegetables.
And?
Vitamins.
And? Symbiotic synthesis by bacteria in your large intestine. It can be added to milk because it's fat soluble. All right. So traditionally, in Jewish culture, males are not circumcised until they're a week old. And my oldest son's pediatrician, first one anyway, last name was Cohen. And we did not have our son we didn't have our son circumcised until the 8th day of his life. And I always wondered, is that because he was Jewish, or that was just when the schedule opened? Because when I worked as an RN, it was the OBGYNs that did the circumcision. Babies were there for 3 days, and if the parents wanted their baby circumcised, babies had no say about it because they couldn't talk. And they were usually done on the 2nd day. And then they were sent home. But, I'm not familiar with all the state laws in nursing now, but I'm pretty sure almost every state has a law, unless the parents sign against it, that babies get an injection of aquamaphyton within 20 minutes after birth or so. Is usually when they're done. By the time that's not ruled, but by the time the parents are, when the baby goes off to the nursery for weighing and all of that, if it's not done in the delivery room, it's its first bath and so on. You get silver nitrate in the eyes in case the mom has venereal disease, gonorrhea, and a shot of aquamaphyton, which is vitamin K, and it's anterior thigh. That's where most of the muscle tissue is in a newborn. Okay, so just to prevent, because it takes them surprisingly a week to get the bacteria. They're not born with bacteria in their gut, so to get the bacteria to migrate to the large intestine, it takes about a week for normal vitamin K levels to be reached. And vitamin K and alpha-1 is just another name for the same thing. So if you're pre-fit, clots are being formed just because your blood vessel decided it's a good thing to happen. This is where viscosity, shape, would increase likelihood. So if you have increased viscosity, blood flow slows down, clotting factors are not diluted, and so that can subsequently lead to more likely activation, but more because the platelets are going to stick. So we have other, antithrombin is something your body makes. Heparin C and Coumadin are just plain heparin. This is not the heparan sulfate of your basement membranes that was spelled with an A-N. These two are drugs. Well, the rest of these are all drugs. So anybody know the difference between, they have different effects. Coumadin blocks vitamin K, which activates, you recall vitamin K is associated with prothrombin, okay? So the liver makes prothrombin and needs vitamin K to do that. So Coumadin keeps the liver from utilizing vitamin K to make prothrombin. So it's kind of a couple of steps back. Coumadin is an oral anticoagulant. It's not the most common now. There's others, Ziltril, there's a couple that are advertised, that are probably used more often than Coumadin, and heparin's an intravenous. So heparin can be given usually in the hospital. It's also given if someone has an IV, but it's not hooked up to an IV line. Maybe it's just so they can take antibiotics twice a day, and they'll just kind of flush it, or flush the needle with that. And I was talking about the alternate, I don't know what it is, I'll see if I can.
And I think it's a new one.
They advertise it on, well, the reason I mentioned is a friend of my husband's used to work at his company, and 2 years ago, her husband has an enlarged heart, like half of his heart wasn't working. So they did a surgery to remove part of it, and in other words, so that what was left was more effective. But to look at him, you wouldn't think that he has heart problems. And then 3 years ago, she herself had a heart attack. He's about 20 years older than she is. She's like in her mid-40s. She had a heart attack. So they put her on blood thinners. And she was in St. Louis a year ago, and had come back to the hotel with her friend and said, I don't feel very well, I'm gonna go up to my room. And her friend said, she had a splitting headache, and her friend said, well, keep your phone on, keep your door unlocked, I'll come in and check on you. Well, about 30 minutes later, she called her upstairs to the bar downstairs and said, I really don't feel good, can you come upstairs? And the friend took the elevator upstairs, and here she was, half sprawled on her bed and half off her bed with her clothes half on and half off, and just not feeling well at all. So the friend got her dressed, helped her down. I said, why didn't you call the ambulance to come? And she didn't think the gurney could make it up the elevator. She totally forgot about freight elevators. And so she takes her friend downstairs. Her friend threw up all over her in the elevator. And they'd just been to dinner, so the paramedics were just sure she was drunk. And her friend's like, no, this is not like her. She has a heart condition. And she told them specifically what hospital to take in the city because she used to live there, and she knew which hospitals were good for stroke victims. And the woman had had a ruptured blood vessel in her brain. And because she was on the anticoagulant, of course, that just, and that just made it worse. And I was reading about it, and they always, even though it can cause bleeding in the brain, they always put them back on it because they're at greater risk for death from a clot stroke than from the bleeding stroke. It's just when they put it back on, it was variable. So they took off a piece of her skull, put it in the freezer, liquid nitrogen, while they tried to get this bleeding and the swelling to decompress. It was about 10 weeks before they could put it back on. And then her company paid for a private health care type plane to fly her back to Denver, and she went into Craig's, which is one of a few rehab hospitals. She ended up having 2 strokes. One was from the bleeding, and one was a clot. And so it's like,
Both were hemorrhagic though.
yeah, but the clots, you don't want to give this to someone who has a bleeding, they're both cerebral vascular, not
Not hemorrhagic, or
right.
yeah.
So-
Ischemic.
So if you give, yeah, they're both gonna cause cell tissue loss. So if you wanna give streptokinase if a clot is blocking a blood vessel, because that breaks down the fibrin threads, all right, whether it's a clot in the heart, or a clot in the lungs, or a clot in the brain. However, if the cerebral vascular, the stroke is due to bleeding, this is gonna make it worse. It's gonna increase the loss of fluid because you're not gonna get the little clots forming to stop it. So someone has a stroke and ends up in the ER in that magic, what is it now, 60 minutes, 90 minutes, to stop the effects, the second effects of a stroke. They don't wanna just give this automatically. They need to check and see what the cause of the clot is. Now, aspirin is often described as a blood thinner. It does not affect viscosity, all right? So it doesn't make the blood any runnier. It keeps coagulation from occurring by inhibiting thromboxane. So it keeps the platelet effect from triggering clot formation. So I told the class last night, my husband takes a baby aspirin every day. And I always thought, wrong term for the pill because babies aren't supposed to have aspirin. So the word baby is in reference to the amount, the size, the amount of drug at 81 milligrams, okay? So I want you to know what these 5 events or molecule substances do. I don't know if I told you so the body makes this molecule called plasminogen, which is not, so don't confuse that with the thromboplasmin. Sounds similar because they both have the PLAS sound. Plasminogen is the inactive form of plasmin, which is it breaks down the fibrin threads back to fibrin. Okay? So plasminogen is going to put the arrow on the other end of this. Or plasmin. Plasminogen is the inactive form. So plasminogen is just like fibrinogen was the inactive form of fibrin. Plasminogen is the inactive form of plasmin, and plasmin takes the threads and returns them to soluble proteins. We can't do that with Zello though. I suppose you can figure out a process to dehydrate it. So I told the students last night, and I may have told you in fourth grade, I don't remember. We were talking about something else. But I had a couple of babies that I helped deliver. The last summer I worked with an OBGYN nurse. One was Marianocephalic that was born with only the brainstem. I told you about that last semester when we were talking about the brain. But within a week or so also of leaving Maryland to come out here for my doctoral program, and I kind of remember telling you this, I'll go ahead for those who didn't have me, was a couple that had tried for 10 years to get pregnant. And she was close to her due date. In fact, on her due date, she had a doctor's appointment with the obstetrician, and the obstetrician couldn't find the fetal heartbeat. So the doctor sent the parents over to our hospital, and she showed up a little bit later, but we'd already determined that there was no fetal heartbeat. And so the doctor and the parents were ready to do a C-section. The baby had already died, the mother was not in labor, and just go ahead and remove the dead fetus. But the rest of the doctors on the floor convinced the OB that this was major surgery, and the mother was not at risk, and it would be hard to justify doing major surgery when the baby had already died, you didn't need to get the baby out quickly, and it put the mother at risk. So the mother was given prostaglandins she wasn't effaced or any kind of form to kind of get her ready. There's no point inducing her because the cervix wasn't right. So she was given prostaglandins to help get her to that point, set her fever up over 104. So they put her on a cooling blanket. 3 days later, she gave birth to her little boy. And another nurse and I delivered the baby. The dad was there and the doctor was on her way. And the baby looked fine. You know how post-term babies their skin starts to slough off from too much exposure? This baby, except for not being alive, it didn't have a cord around its neck, it didn't have any visible damage to it. It was just a beautiful little boy. And by then the doctor was there, so she took the mom into the OR to deliver the placenta and the rest of the decidua. And she was in there for at least 5 hours. So I was in the labor room with the dad. And keep giving her, they must have given her 10 units of blood. And so what had happened was, she had a clotting disorder. Which you might say, well, obviously, her blood didn't clot. But it's called disseminated intravascular clotting disorder, or DIC. Anybody know what disseminated means? When someone disseminates ideas? To spread out. Okay? So it wasn't that she had an issue with clot formation. Well, she did, but the original cause, well, let me rephrase it. The original mechanism, the original cause wasn't known. So, as a result of either the prostaglandins that she was given to start the process of being ready for labor, or toxins from the baby, although he didn't smell, there wasn't any appearance of decay, toxins from the baby being dead in her uterus for so long, either of those could have caused a massive dissemination of tiny, tiny, tiny little clots throughout her body. So tiny that they didn't affect her vessel function, but enough of them that they used up her clotting factors. So that when there was a need for the uterine vessels, the spiral arteries, for the blood in those vessels to clot and stop the bleeding once the placenta had separated, it didn't happen. Because she had used up most, if not all, of her clotting factors with all these tiny little clots. And so she had done too much clotting to have enough clotting factors available for when she actually needed bleeding to stop in the placenta. They didn't have to do hysterectomy. Okay, they were able to finally get it to stop by adding additional clotting factors, not just giving her blood. And so I went to see them before I left the hospital, moved out here, and they were obviously not on an OB ward. It happened after 10 years of trying. I don't know what they ended up doing, but at that time they were done with having their own kids and were going to look into adoption. Okay, last question. Yes.
Oh, yeah.
Now that we've covered the topics. Every answer for 4 or every question?
Every question.
Oh, okay. All right, anybody, any more time on 4? And 5? So coagulation, which occurs after blood is drawn into a glass tube, a vacuum tube for collection. If it hasn't been treated with heparin sulfate or calcium chelators, the blood will clot. Is that a result of activation of the intrinsic pathway or the extrinsic pathway? Okay, so let's go back and revisit this slide. So when I wrote it on the board, when I drew that pathway, common pathway on the board, all right, over here, we got to the factor X by thromboplastin. Over here, anybody remember what I wrote?
Abnormal surface.
Abnormal surface.
That's the glass.
That's the glass. The needle going into the blood vessel is not causing the cells surrounding the vessel to produce
So
thromboplastin.
the needle insertion does not cause enough damage. Okay.
So we're taking the blood out of its natural environment, putting it in the glass vial. That glass vial has negative charges on its surface. And that surface that's not normal to what the blood is going to trigger all of this, which is already in the blood cells. And the thromboplastin is not needed. It seems like it's outside because the blood is outside the vessel, all right, but we haven't added any outside chemicals. Does that make sense? So the intrinsic versus extrinsic is talking about cause. Are we adding any clotting factors to the blood when we put it in a glass vial? And we're not. It's just changing the surface.
Extrinsic or added?
Extrinsic, think of outside. So extrinsic, we're adding an outside factor. Intrinsic, we're activating factors that are already in the blood. So if we go back again to this pathway, so extrinsic, we're adding the thromboplastin. Intrinsic, we're activating what's already in the blood. We're not adding anything new. And the collagen on the vessel wall or the negative charges of the glass surface are both activating chemicals, molecules that are already in the blood. We're not adding anything new to it. Okay? So intrinsic means within, extrinsic means without. Okay? So if it helps to think of exiting, going out, extrinsic, it's already out coming in, but it may, whichever that helps. Okay? So one more view of that. Okay, the last couple things I want to mention are the fancy terms for clot and a moving clot. All right. So deep vein thrombosis, DVT, is how it's often described or talked about without ever saying what the words mean. And thrombus is a coagulation that occurs at site. So atherosclerosis, the addition of adipocytes in the smooth muscle, phlebitis, inflammation of the vein that leads to a platelet sticking there, that's a thrombus. Once that thrombus breaks off and travels, it's an embolus, okay? So emboli do not have to be blood clots. Emboli can be air, emboli can be oil or lipids. So bone fracture can release adipose tissue from the yellow marrow of the medullary cavity, and that itself can cause an embolus. Okay? So the last slide is just a picture of somebody that has insufficient numbers of platelets. So leukopenia with not enough white blood cells. They would have difficulty fighting various infections. Thrombocytopenia can lead to bleeding problems, kind of like hemophilia, but for different reasons. With thrombocytopenia, you don't have enough platelets to plug any leaking, damaged vessels, and so the blood leaks out of the vessels into the tissue. But it's under, yeah. This is hemophilia. We have I have a colleague here in our department who has thrombocytopenia, and she actually took a leave of absence and took some natural, quite folk medicine, but you know, the ancient herbs and stuff, and it's helping her a lot. All right, the last thing I want to do is to look at some practice. This is actually an old quiz. So this is one of the ways in the past I've asked blood typing questions. So, in reassurance, you can see that on over here I've given a code or a key as to what agglutination is and no agglutination. I'm not testing you on whether you can pick that out or not. Okay, I'm testing you on your ability to translate what's going on. Okay. So this is agglutination, this is not. All right, so we add the antibodies to A or to B or to D, similar to what you did to lab. So what blood type would this be? AB, negative, all right? And here, O negative. And here, A positive, because we have the A antigen, we have the D antigen, and we have no B antigen. So again, in typing, we're looking for the antigen. We're not worried about what antibodies are there. These are extrinsic antibodies, if you will, that we've added from the outside. Okay? These are platelets here. If you didn't have a chance to see platelets in the microscope, there are more platelets here. So what blood type are we looking at here? Lymphocytes. You can see a little bit of clear cytoplasm. Sometimes you can't, but here you can. And they're just slightly larger than a red blood cell. Okay? Red blood cells are about 7 microns, 7 to 7.5 microns. These are around 8 to 9. All right, what would this cell here be? A monocyte. Now sometimes in this particular image, the red blood cells are really dark pink, and this is almost a bluish nucleus. Sometimes it's a pink nucleus, okay? But it's often kidney shaped, and it has this modeling that you see in the nucleus. Here, anybody see this cell tonight? Eosinophil, okay? More platelets in here. Yes, neutrophil. So you can see it looks a little narrowed here. Here it's hard to even see where the band is. But remember, another name for neutrophils are polysegmented. So they all still connected on just one nucleus, but they're connected sometimes by thin strands, and they have fine, tiny little pink granules here. All right, what do we have over here? Somebody found one last night that looked almost like that. The nucleus is weird, but look at the size of the cell. And here we can see some white spots within the cytoplasm itself. A monocyte. Okay? Here. Now here the red blood cells are bigger than here, so everything's bigger just because of the magnification. So these two cell types are the same. They're both neutrophils. Okay? And up here, another lymphocyte. You can clearly see the edge of the cell there. All right, what do we have here? Basophil. It's actually another eosinophil. The granules are much more distinctive there than they are here. Okay, or here. So eosinophils are pink to orange in staining. Their granules are not as large and coarse as basophils, but you can still see the nucleus. And this one? A monocyte. Okay, this is a bit more typical of the monocyte with the kidney-shaped nucleus and the modeling that occurs in either the cytoplasm or the nucleus or both.